Welcome back to The Explainer. Today, we're jumping straight into the high-stakes, absolute zero margin for error world of clinical toxicology. We're going to break down these massive life-or-death emergencies into a really precise first principles framework. Because let's face it, when you're dealing with a critical overdose, literally every second matters. A reflex diagnosis based on just, superficial symptoms, that can be fatal. But if you actually understand the physical mechanics, the why behind how these toxins work, all that clinical panic just completely fades away. All right, let's run through the mental syllabus real quick. We're hitting autonomic toxidromes first, then moving into metabolic toxins, onto acetaminophen kinetics, and finally, we'll wrap up with a mandatory validation drill to put what we've learned to the test. Okay, Module 1, autonomic toxidromes. We're kicking things off right at the nerve synapse to see how we can instantly tell the difference between two totally opposite systemic reactions that, honestly, can look terrifyingly similar. Before we even look at a patient, we have to get the biology straight. When the autonomic nervous system goes completely off the rails, you're usually standing at this sort of synaptic fork in the road. You have to ask yourself, are we dealing with a massive flood and accumulation of acetylcholine, or is it a competitive blockade of those exact same muscarinic receptors? You've got to figure this out, and you've got to do it fast. Now, this is where you have to be a detective and filter the true signal from the distracting noise. Say you see pinpoint pupils, meiosis. If the patient has a history of drug abuse, your brain's going to scream, opioid overdose. But wait, that's a trap. Yes, opioids cause meiosis and respiratory depression, but you have to look closer. You absolutely must check for profuse sweating or completely dry skin to figure out the true autonomic vector here. So let's bring this to the judge's bench and actually weigh the evidence. On the cholinergic side, think organophosphates irreversibly blocking acetylcholinesterase. The evidence is, well, wet. Remember the dumbbells mnemonic: diaphoresis, urination, meiosis, bradycardia, and salivation, plus those muscle twitches from nicotinic overdrive. Now, flip that. An anticholinergic presentation, like from atropine or TCA overdoses blocking those receptors, gives you a patient who is mad as a hatter, dry, hot skin, absolutely zero secretions, racing heart, and dilated pupils. Bottom line, if they are sweating profusely, you can cross anticholinergic right off your list. Moving right along to Module 2, metabolic toxins, we're dropping down from the nerve synapses and going straight into the cellular powerhouses themselves, the mitochondria. Here's the core first principle of metabolic toxins. They literally create an embargo on cellular respiration. These aren't toxins that just, make you a little sleepy. They violently starve the body of energy at a microscopic level by completely blocking the mitochondrial electron transport chain. The patient's lungs might be working fine, but their cells are suffocating. And this brings us to a huge trap. In these scenarios, your standard monitors, they will straight up lie to you. Take a smoke inhalation victim from a house fire. They're exposed to both carbon monoxide and cyanide. If you slap a standard pulse ox on them, it might read a perfectly healthy, normal oxygen saturation. Why? Because the machine literally cannot tell the difference between healthy oxyhemoglobin and toxic carboxyhemoglobin. It's a deadly false sense of security. Back at the judge's bench, let's compare the culprits. Carbon monoxide physically left shifts the oxygen-hemoglobin curve. It's a competitive oxygen inhibitor. You might see that classic cherry red skin post-mortem. And the fix is aggressive. Blast them with 100% oxygen or get them to a hyperbaric chamber. Cyanide, though. Cyanide violently shuts down oxidative phosphorylation by binding iron in complex 4. You're going to see severe lactic acidosis, a narrowing arterial venous oxygen gradient, and rapid cardiovascular collapse. The antidote here requires actual chemical intervention, like hydroxycobalamin, to actively hunt down and bind the toxin. This scale here visualizes exactly how we escalate care based on how bad that cellular starvation is. It goes all the way from tossing a 100% non-rebreather mask on a stable patient who just has a mild headache and low carboxyhemoglobin, right up to the absolute extreme, deploying IV hydroxycobalamin and immediately intubating a comatose, deeply acidemic fire survivor. The therapy has to match the severity of the cellular embargo. All right, Module 3, acetaminophen kinetics. We're leaving the mitochondria now and heading over to the liver's metabolic pathways to look at one of the most incredibly common, yet sneaky overdoses we see. The physics behind this toxicity is all about pathway saturation. It's essentially a high-stakes game of molecular musical chairs. It all comes down to the desperate, urgent need to neutralize a highly reactive electrophilic intermediate before it literally shreds the liver cells apart. This perfectly breaks down why an overdose is so deadly. Normally, therapeutic doses are safely handled by glucuronidation and sulfation pathways. No big deal. But an overdose? It completely jams up and saturates those pathways. So the drug gets shunted over to the CYP2E1 enzyme, which turns out this highly toxic byproduct called NAPQ. Now, the liver tries to fight back, using its own glutathione stores to neutralize it. But once those stores drop by about 70 to 80%, that's it. NAPQ covalently binds to the hepatocytes and silent hepatic necrosis kicks in. This timeline is exactly why this overdose is so deceptive. The first 24 hours are quiet. We're talking mostly asymptomatic, maybe some mild nausea. It's just clinical noise. But underneath, the glutathione is draining fast. Fast forward to 24 to 72 hours, your AST and ALT liver enzymes start this incredibly steep climb, and the right upper quadrant pain hits. By 72 to 96 hours, the true terrifying signal emerges. Peak hepatotoxicity, a massive spike in PT/INR, and fulminant hepatic failure. It's catastrophic. But because we understand that exact physical mechanism, we know exactly how to deploy the perfect antidote. We know the liver just ran out of glutathione, right? So we give N-acetylcysteine, or NAC. NAC steps right in as a substitute for that depleted glutathione and supplies the sulfur needed to regenerate the liver's own stores. It literally halts the cellular destruction in its tracks. First principles, saving the organ, right there. Which brings us to Module 4, the mandatory validation drill. Enough passive listening, it's time to put your clinical detective hat on. Let's run through some real-world vignettes and see if we can filter the signal from the noise. Check out the evidence in Vignette 1. EMS brings in a 45-year-old farmer. He is confused, drooling, and incontinent. Heart rate is tanked at 48 beats per minute. Crucially, his pupils are 1 millimeter bilaterally. Pinpoint. Oh, and he has a history of severe depression and substance abuse. So, is this an opioid overdose, or is there a signal hiding in all this noise? Just take a second to think about it. Okay, if you filtered out the noise, you caught the massive cholinergic signal. Those pinpoint pupils and the substance abuse history, total trap. They were planted there to distract you. Because think about it. Opioids do not cause you to drool uncontrollably, wet yourself, and have dripping wet skin. That specific combo of wet skin, drooling, and severe bradycardia, that points straight to a cholinergic toxidrome. Given he's a farmer, we're likely looking at organophosphate pesticide poisoning. You reach for atropine and pralidoxime here, absolutely not naloxone. All right, puzzle number 2. A 24-year-old female is found unresponsive in a closed garage with a car running. EMS slops a standard pulse oximeter on her, and it reads a totally reassuring 99%. But her arterial blood gas comes back showing severe metabolic acidosis. So what's going on, and what is your absolute next step? I bet you caught the trap. That 99% oxygen saturation is a complete illusion. It's a false normal because the pulse ox is confusing toxic carboxyhemoglobin for healthy oxygenated blood. The cellular respiration embargo is already happening. That's what the severe metabolic acidosis is telling us. So the chronological next step, immediate, aggressive, 100% oxygen to competitively displace that carbon monoxide, and you've got to instantly evaluate her for hyperbaric therapy or hydroxycobolity. As we wrap up this explainer, I really want you to take this to heart. Understanding cellular first principles is the ultimate antidote to clinical panic. When you truly grasp the underlying physics, whether it's synaptic accumulation, mitochondrial starvation, or pathway saturation, all that distracting clinical noise just fades away. You're left with absolute clarity on what's happening to the patient's cells and exactly what you need to do to save them. So the next time you're thrown into a chaotic emergency, ask yourself, are you just reacting blindly to the noise, or are you hunting for that undeniable biological signal? Keep digging, keep learning, and I'll catch you in the next explainer.